Okay, let's jump right into this explainer. In a cerebral vascular crisis, you are literally losing 2 million neurons every single minute. Time is brain, right? So today, we're executing the 280+ execution protocol for stroke management. We're cutting out the fluff and focusing purely on high-yield clinical reflexes.
Here is our execution protocol for today. We'll start with cortical strokes and the homunculus fork. Then we move to brainstem dynamics, followed by hemorrhage. Finally, we'll wrap the whole thing up with a mandatory clinical validation drill.
All right, Module 1, cortical stroke syndromes, the homunculus fork.
So when a patient rolls in with a focal neurologic deficit, you need to instantly filter out the clinical noise. Forget the remote history of TIAs or those subtle carotid brutes for a second, and anchor to your first principle, the somatotopic organization of the brain. The exact mapping dictates the presentation. Literally, the physical deficit they have tells you exactly which vessel is occluded. It's like a highly specific zip code.
Now, looking at these vascular territories, it makes perfect sense. The anterior cerebral artery, or ACA, supplies that medial cortex, which is home to the leg portion of the homunculus. On the flip side, the middle cerebral artery, the MCA, covers this massive lateral surface, heavily targeting the arm and the face. Let's put this on the judge's bench to separate the two. If you see face and upper extremity weakness combined with aphasia, meaning a dominant hemisphere lesion, or maybe hemineglect in a non-dominant lesion, boom, you rule in the MCA. But if you're looking at isolated lower extremity weakness paired with urinary incontinence, you need to pivot immediately to the ACA.
Sometimes, though, that sudden onset physical weakness looks basically identical. That's when you split the pathology by checking the extras. Language deficits, that points straight to the MCA. But if you see frontal lobe personality shifts, maybe a severe lack of motivation, known clinically as abulia, that's a massive red flag for the ACA.
Moving right along, Module 2, brainstem dynamics and acute interventions.
Our absolute first principle here is longitudinal column integrity. The brainstem is, quite frankly, incredibly tightly packed real estate. Just as a general rule of thumb, remember that medial structures handle motor functions while the lateral pathways carry sensory and autonomic data. Locking that in will literally save you from getting lost in a maze of cranial nerve deficits.
Let's look at the absolute classic test of this, lateral medullary syndrome, or Wallenberg syndrome. If the posterior inferior cerebellar artery, the pica, gets occluded, you hit that lateral column. So what do you watch for? You're looking for a loss of pain and temperature on the ipsilateral face, but the contralateral body. Add in some vertigo, hoarseness, and an ipsilateral Horner syndrome. You know, that classic triad of a drooping eyelid, constricted pupil, and lack of sweating. And you have absolutely nailed the pica territory.
Okay, when the clock is actively ticking in the emergency bay, you have got to follow this exact chronology map. A sudden focal deficit demands an immediate, non-contrast head CT. Why? Because we have to completely, 100% rule out a brain bleed before we even think about touching blood thinners. After that, you grade the severity with the NIH stroke scale, and then you push for revascularization.
Here's the thing you already know but need to keep front of mind. A negative early head CT does not rule out an ischemic stroke. Those infarcts love to hide early on. But what it crucially does is rule out a hemorrhage, which green lights our thrombolytics hours before you're ever going to see that definitive bright white damage on an MRI.
You really need to lock in this severity invasiveness matrix. An emergent presentation under 4.5 hours from their last known well time with zero bleeding risks, that buys them IVTPA, the clot buster. But if we're dealing with a critical large vessel occlusion, even up to 24 hours out, that requires a mechanical thrombectomy. We physically have to go in there and pull the clot out.
And there is a brutally strict hemodynamic threshold here. To administer TPA safely without converting a standard ischemic stroke into a deadly hemorrhagic one, the patient's blood pressure must be absolutely suppressed below 185/110. Under no circumstances do you push the drug above this line. It's a hard stop. Before we leave the brainstem entirely, let's lock in this clinical pearl. Crossed sensory signs, like right facial numbness combined with left body numbness, that is the absolute definitive red flag for a brainstem lesion. If the entire deficit is unilateral on just one side, you're looking higher up at the cortex.
All right, let's jump to Module 3, intracranial hemorrhage. So here, the pathology violently switches from a lack of flow to an explosive excess of it. Everything in traumatic hemorrhage essentially boils down to kinetic pressure forks. You have to ask yourself, is this bleeding a high-pressure arterial blowout tearing spaces open rapidly, or is it a low-pressure venous slow leak creeping over days, maybe even weeks?
Back at the judge's bench, we contrast the two main culprits. On the arterial side, trauma to the side of the head ruptures the middle meningeal artery, creating an epidural hematoma. You're going to see a biconvex or lens-shaped bleed on a CT scan because that intense arterial pressure is literally peeling the dura off the skull, but it gets stopped dead at the tight suture lines. On the venous side, tearing the bridging veins creates a subdural hematoma. That's your crescent-shaped bleed that freely crosses suture lines, just molding right around the brain.
Clinically speaking, the presentations are night and day. Your classic epidural patient gets hit in the head, loses consciousness, wakes up completely fine in this highly deceptive, lucid interval, and then they rapidly herniate and crash as that arterial blood aggressively expands. Conversely, an elderly patient with a subdural venous bleed might just show a subacute cognitive decline and confusion stretching over weeks, all from a relatively minor bump to the head.
Okay, let's test this. Module 4, Mandatory Clinical Validation Drill.
Let's put this theory into practice with two quick vignettes. Vignette 1. A 74-year-old female with atrial fibrillation suddenly ignores the left side of her body entirely and has a right-sided gaze preference. Vignette 2. A 62-year-old male presents with vertigo, hoarseness, and a crossed sensory deficit, specifically right face and left body pain loss. Take a second to localize these lesions.
Applying the filters we just covered, Vignette 1 is a classic right middle cerebral artery occlusion. The left-sided hemi-neglect tells us it's the non-dominant hemisphere, and that gaze preference is pointing right toward the side of the lesion. Vignette 2, that perfectly describes Wallenberg syndrome. It's an infarct in the lateral nadella, specifically sitting in the pica vascular territory. Now, reordering our findings into a real-world timeline, your immediate actions for ischemic patients have to follow this strict chronological pathway. You secure the airway, get that non-contrast CT to rule out blood, aggressively manage that blood pressure, keeping it under 185/110, and then you clear the patient for clot-busting therapy if they are within that crucial 4.5-hour window.
I'll leave you with this final, provocative thought. Imagine the CT is completely clear, and the blood pressure is perfectly controlled. What is the single most critical next step you absolutely must verify in their history or labs before pushing TPA, just to avoid a catastrophic, fatal bleed? Think about their anticoagulant status, lock in your answer, and carry that reflex with you into the clinic. Thanks for jumping into this explainer with me.